Okay, one thing before we get started, I just wanted to show you guys. If you have to miss class and you want to hop on the Zoom while class is happening, I did put a link right on the home page. It says join my Zoom room right here. So if you have to watch from home, this you can I use my personal Zoom room for my recordings. Also, if we like sometimes I'll meet with students, you can't meet during office hours or whatnot. And so we'll just meet over Zoom. This is a direct link to my Zoom room. So just to make it easier for you to find way to access me. All right, so let's go back over to the Menti. All right, anybody need another minute to get in? Maybe I should write the number on the board, right? Let's see. It's hiding. Let's see, 80, 94, 87, 5. If you're somebody like me that gets numbers switched, grouping them like I just did can be very helpful. I was always worried I was going to make a dosage error when I was in school and early, but grouping numbers helps. Okay, so today we're going to talk about pain. I can't remember. I tried a little bit something different with how class is going to flow today. So it might be in this order, it might not. Either way, we're going to kind of be on the Menti for all of class, and we'll kind of break off and do some group work. We'll go back to the same Menti, so you don't have to join or rejoin different ones today. All right, so pain and CAM scores. I think before we even get into it, something I think pain is important to think about because it's something we all experience. It's a universal experience that people have. However, even though everybody experiences it, it's very different in how we experience it. And when we have medical conditions, injuries, issues, it causes pain. And so that's a lot of in the medical field, we're dealing with pain and how to treat it, how to fix it, how to figure out what's going on. It's kind of a pervasive theme through the medical field and through nursing. Excuse me, I'm sorry, like this clog in my throat this morning. So there was a study of pain in 2020 that defined pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Um, excuse me, I'm so sorry. And I think about that actual or potential tissue damage. It makes me think of people with heart attack, right? Like you might start having some chest pain if those coronary arteries start getting where they're not getting as much blood as they need to. There might not be tissue death that's happening. There might not be actual damage yet, but they're saying, they're sending a signal to you, I'm not getting what I need. My tissue is going to be damaged very soon if I don't get what I need. And so it could be actual or potential damage with this. It's kind of sometimes that helps me to understand. Margaret McCaffrey is a nurse, and in 1968 she wrote this quote that's often used when we talk about pain, and it's that pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. She was a massive leader as far as a pain revolution, as in nursing. She worked in the NICU. And she worked with babies, and she noticed in the NICU all of these babies were in their little isolates, in their little thing. And this was like, this was a long time ago. And they were quiet and they weren't crying. And one thing that she finally realized is that a lot of them, it's not that they weren't hurting or they weren't scared, is that they were hiding. Because these little babies have been exposed to so much trauma and so many medical procedures and so many things to keep them alive that they were trying to hide and be quiet. And when she realized that, she was like, okay, because back then there's a lot of times they're like, no, babies can't feel pain. Babies don't have pain like we have pain. Right. And we know now that's not true. Babies do feel pain. But she was a big leader in revolutionizing how we treat not only babies, but everybody else. I think there's we go through shifts in medicine, right? With how we treat things, how we view things. Part of her revolution that she started with her revolution, the revolution of pain management, it swung more towards let's treat everybody's pain. Let's do what we need to do what we can. I think we maybe came a little bit too far to the other side with maybe over treating, maybe over prescribing some opiates. We've seen a lot of the fallout of that. right? With addiction and misuse. And so just like anything in the world, we're trying to get those pendulum swings where they kind of come back to like a more normal, maybe what's best for all, right? Because we don't want to not treat pain, but we don't want to make it so accessible and have people primed for addiction as well. So we're trying to kind of find this nice balance. Okay, so key points about pain that I think we all, I want us all to kind of think about is that pain is a personal experience and it's also shaped by people's, like, by life events, right? Somebody who's experienced a lot of trauma in their life, they might be more sensitive to pain, that stimuli that causes pain. The patient's self-report of pain is the gold standard, okay? So if there's ever questions that come up for me or with the NCLEX or anywhere that talks about how do you know if a person's experiencing pain, the number one response should be if they tell you they're in pain or not, right? That's the priority of what we're going to look at. It's not the only thing we're going to look at, right? We're going to look at a lot of other things as well. And then also, pain can affect people negatively. It can be a big emotional, a social barrier. It can affect them spiritually and even financially, right? Somebody's having a lot of pain and they can't work like they need to. They might not be able to have income, and that's going to affect them. There's a couple different types of pain. So we talk about acute pain. So that's when I don't look what I'm doing and I slam my finger in the door, right? That is acute pain. It happened right now from an injury. It's usually less than 6 months, or pardon me, less than 3 months as far as a time length, but it's less than 6 months. Sometimes acute and chronic pain kind of blend a little bit together. So we use these time frames, right? My finger from being slammed in the door probably will not hurt more than 3 months, hopefully no longer than 3 days. But my symptoms should lessen over time. They're going to get better as that tissue kind of gets a little more healed. It does prompt an inflammatory response, right? I slam my finger in the door, what's going to happen? Right. It's probably going to swell, right? My body, and it's swelling. That's my body's natural response trying to give more structure. We maybe put a cast or those external fixators like we talked about. Our body puts extra fluid there to try to reinforce that area, to give it more structure and protect it. The signs and symptoms are usually short term, and a lot of times they're objective, right? Remember we talked about in foundation subjective and objective data, right? And so the subjective is I say my pain is a 5 out of 10 when I slam my fingers throbbing here. The objective, it might be an increased heart rate, right? That's something we can actually see and measure. What might be some other objective data that we can collect from patients in pain? If there's swelling, redness, if it's warm and hot. Sometimes I look at their respiratory rate. Sometimes I'll look at their engagement with things around them too, right? If I have somebody with their pulse, yeah, with their heart rate. No, you're good. Some respiratory rate too. Sometimes people's respiratory rate will go up when they're in pain. I also look at what they're doing, right? Because I've had patients who come in with maybe they slammed their finger in the door and they broke their finger and now we're fixing it, right? It's an acute pain. And they're saying, my pain is a 10 out of 10. And they're eating potato chips and they're playing on their phone and they're laughing with their friends. Does that mean that their pain is not a 10 out of 10? I don't know. I can't say. That's a subjective like number because people experience it differently. What I do with that number does help guide them, right? Because for that person with that acute pain, they're saying it's 10 out of 10, but they're still able to engage with the world around, right? They're talking with their friends, they're on their phone, they're able to eat and drink. I can look at that objective data to guide me in how I treat them, right? Do I need to go grab some IV opiates to give them to control their pain? No. Probably not, right? Like we don't need to go that far. Let's start with some other things to help treat the pain. Now, if we go to somebody that has chronic pain, that's usually when it lasts longer than anticipated time. So it's just something that's kind of lasting longer. I think about people that have injured their backs. A lot of times people have chronic back pain. maybe they twisted or they did something and it just does not get better like we maybe would expect it to. Usually chronic pain longer than 6 months. A lot of times you'll see this years, right? Like, how long have you had this pain? 10 years, right? It's been going on for quite some time. The signs and symptoms are persistent. They don't go away. It might have fluctuations or variations in how they feel, but it doesn't ever just go away completely. And this is the thing, people in chronic pain, they have learned how to cope with the pain. And so often they don't seem like they're in pain. They have learned all these mechanisms and things to do to help them deal with that pain that they have every day. So while that person in chronic pain, they might say, I say, what's your pain? You've got this back injury, and they might say, it's a 10 out of 10. I live here every day. And they're still eating and they're doing all their things and they're on their phone. That's another person. Does that mean that they are not a 10 out of 10? I don't know, right? We have to go off of what they say. That is one thing I want to make sure that some people, especially when we're talking about documenting, right? Because if we're doing our assessment and somebody says, I'm a 10 out of 10, I'm 8 out of 10, you're like, there's no way. Like, I just asked you if that's the worst pain possible. And you say yes, like, but that sometimes it doesn't seem to relate, right? Does it mean we don't document it? Well, no, it means we do. We document it. But what I suggest you guys do is just write a little note or a comment. And I would say for the person who like smashed their finger, I would say, yeah, patient reports pain of 10 out of 10. And I would say, patient noted to be eating their chips, able to laugh at videos on phone, visiting with family. I might state the vital signs, just give some objective data to go along with it, right? Now, the person who is 10 out of 10 pain with their back and that's chronic, I might also say, yeah, patient reports this. I'm going to also do another ask of this patient too, right? Because with chronic pain, it can be very different how it presents. Sometimes with back pain, it can start traveling. It maybe moves down their legs. They might have numbness and tingling with some nerve involvement. It's going to feel a little differently. And I'm still going to say they report 10 out of 10 and they are able to engage in life with whatever they're doing. I'm going to write a little note about it. Am I going to treat them differently? Probably, right? The person in chronic pain, hopefully they have a medication regimen or a treatment plan, something that helps them control that pain. And I want to help contribute to that. A lot of times with chronic pain, we notice that these patients can have a lot of mental and emotional side effects, right? If you've had any kind of pain for an extended length of time, it makes you crazy almost. I mean, I shouldn't say that word, but just it makes you so frustrated. It makes you feel like, are you able to do anything? And people who live with this for a long time can really suffer. And so we want to make sure we're evaluating our patients for that. We might be making recommendations for counseling, for just whatever other needs they might have. Suffering. So when we talk about pain, I think it's important that we also think about suffering, because we also, we say like there's pain and suffering, right? Well, there are two different things. Pain is that physical response that we're having, and suffering, it's that feeling. It's like the emotional feeling of being in distress, that something is wrong, right? You might have somebody who's having suffering without pain, right? When I've lost loved ones, when they passed away, I have felt suffering, right? I am sad. I miss them. Is it emotional pain? Yeah, maybe, but usually we kind of refer to it more as like it's the suffering piece. It can be relieved with the belief that comfort can be achieved. What that means is if you have suffering, just that feeling of distress, if you have hope that it can get better, a lot of times it can relieve that suffering. You might still have the pain, but you've got hope that this can get better. And that actually can kind of spiral in a good way of helping people to feel better. You want them to have hope. Spiritual coping can often be a source of comfort for people. They might pray or meditate. They might seek counsel or be like in other groups. Whatever it is that helps them spiritually can really help alleviate that suffering. So risks. Why do we want to help control people in pain? Not control them, but help control the pain. Well, a big part is because we know there's a lot of negative side effects that come from uncontrolled pain. our bodies can release some kind of harmful substances when we're in pain. It causes an inflammatory response, and it can kind of cascade with how it really affects us. Studies have shown patients that have surgery who have poor pain control, they're having a lot of pain afterwards, it's not dealt with very well, they have an increased risk of morbidity and mortality. Which means they have increased risk of dying within 6 months after surgery when their pain isn't controlled well. Which to me, when I first heard that, I was like, oh my gosh, like it isn't just like teach, like, you know, just deal with it. It's like, no, we need to actually make sure we're helping with these patients so that they can live full lives, right? Like it's one thing to make sure that we prevent blood clots and prevent pneumonia and have the wound heal really well. But if they're dying or have increased risk of dying 6 months afterwards because their pain wasn't well controlled, well, that's a big deal. I don't want this patch. Get rid of you. Okay. Oh, gotta click back on my slide. Okay, so cultural considerations. Not every culture expresses pain in the same way, right? Yeah, hopefully we've seen this as we kind of move through life, but there are some cultures that express pain very loudly and for everybody to see. There are other cultures that they do not want to show anybody pain. That is something that is private, that you do not talk about or show. And so that's one thing I want us to be aware of, especially as we start going to clinicals in the fall, is that when people are having pain, different cultures are going to show that and express pain or not express pain in a different way. We want to make sure that we follow ethical principles in general with pain. We'll talk about that a little bit more. All right, so I know I kind of went for a long time without asking you guys questions on the Menti, but when we're planning somebody's care, which definition of pain is the most important? All right, you guys are doing fantastic. And I did kind of tell you earlier, right? That when we talk about the most important, because these are all true statements, right? Typical nursing question. Every answer is correct. There's just one that's most correct. So it's whatever the patient says it is. When we're planning care, we have to go, I remember that's the gold standard. It's whatever the patient says it is. That's what we got to go off of. So let's think for a minute. You're caring for a patient who's 1 day post total hip replacement. So when we say 1 day post, that means they had hip surgery yesterday. You can, sometimes they'll talk about post-op day is the day they have surgery. Post-op day number 1 is the first day after surgery. Post-op day number 2 is the second day after surgery. So that's kind of in the medical world, how we talk about like post-op days. All right, so they're post-op day 1 after hip surgery. The patient refuses pain medicine, even though he appears to be in pain. Okay, so there's some sort of objective data that makes us think, oh, maybe he's hurting. So I want you to turn to your partner or somebody around you and talk about what would you do if this was your patient? You think they're in pain, but they're saying no. Sure.
So yeah, you have those patients where they just don't want
All right, let's bring it back together. So if we think they're in pain, let's do a pain assessment, right? Let's talk about it, right? Let's ask maybe the question, why are they not taking pain medicine? There's oftentimes people have perceptions about taking pain medicine. They don't want to become addicted. They don't want to be a junkie or a druggie. I've had many patients say that to me. They're like, oh, no, I don't want to be a junkie or druggie. I've seen that. I don't want to do that. And I think it's important that we find out the reason why people maybe don't want to take medicine. And then we also want to see, what are they capable of? Because if this guy is saying, I think it was a he, If he's saying, no, I'm not in pain, and he can still get up and he can walk and he can work with physical therapy, he's eating his food, he's doing what he needs to do, he might not be in pain. Maybe he's stressed because he just got a phone call because his bank got hacked and now his finances are in a mess, right? Like I don't know. There might be other things going on, but I want to see, because if he says I'm not having pain, I can do all these things I need to do, and he's able to function pretty well. That's good. We might want to also do some education, because he might need analgesics, right? He might need some pain medication if he can't do what he needs to do to heal and be healthy. There's also some things we can talk about. Sometimes people don't like the pain medicine as much. Hey, let's talk about some ice. Let's talk about elevation. Let's talk about some other things that maybe aren't medications itself, but that can help with the pain, that can help you be more functional. Who's responsible for pain management? Well, everybody. It's all of us, right? But the piece that I want us to think about is that the patient is the center of their healthcare team. We talk a lot about the healthcare team in general with patients, so that they are the ones that should be making the decisions and kind of steering the course of their care. Now, there's a lot of people in the healthcare team, right? We think a lot of times as the doctor might be the head of the healthcare team, and they definitely are the most educated ones, right? They're the ones who went to school the longest, that are the experts at whatever subject we're talking about. And they're going to give, hopefully, direction. They're going to guide us into, like, saying, this would be, most people with this, whatever happened, they do better if we do this treatment. Or most people have a good response if we do this. And then the patient is the one that's deciding, right? But we're all there helping and supporting. There are some regulatory bodies that do kind of mandate some things with pain control, the Joint Commission, state licensing boards. There's very specific things that go with that. I recently was working at the hospital, and we had epic downtime. And so if you've experienced epic downtime, it just means the computers don't work and everything's back to paper and people go crazy. I was like, guys, we worked for many years, centuries without paper documentation. We could do this. But one thing, I was really thankful for one of our providers, because we were trying to send somebody home and she was writing discharge medications, and she only had one sheet for the prescription. And she goes, wait a second, I need another sheet for the prescription, because his opiates, the oxycodone I'm prescribing for him to go home on, that has to be on its own individual sheet. And I was like, oh gosh, thank you for remembering that. Because when we do electronic prescriptions, I don't think about that sometimes. But that's one of the regulatory practices, to keep people from altering prescriptions or kind of, what's it called? Forging things. Like when you have a pain medication script, it is the only thing that is on that prescription. Even though in like the old school prescriptions, there were like 8 boxes, they could write like 8 different medicines on there. And so that's one of the things that's been regulated, at least in the state of Washington, that you have a big thing, a big prescription, you get to write one pain medicine on each whole page. So let's talk about addiction. People are often very afraid of being addicted, especially, like I said, how the swing has gone from really not treating pain very well to maybe over treating it or making opiates more accessible than maybe they should be. There's a couple different terms I want you guys to understand. So tolerance. Opiates are one of those medications that you develop a tolerance to. And what that means is, if we have somebody who has, let's say, our chronic pain person with their back injury, if they take opiates, another word for opiates is narcotics. So I like to say opiates because narcotics makes me think of the police and like not using it well. Opiates just makes me feel like it's more medical. You can use whatever term you want to. Especially when I'm talking to patients who are afraid of taking pain medicine, I feel like opiates is a safer term. So opiates, you start taking oxycodone for this back injury. They've done all these other things, but that's really what helps. After about a week, that same pain medicine, maybe he's on 5 milligrams, right? After a week, it's not working as well as it used to. They might have to increase it. Maybe he's going to have to take 7.5 or 10 milligrams. After a while longer, that's not going to be as effective. They're going to have to keep increasing the dose more and more. Now, does it mean that he's addicted to them? No, it just means he's developed a tolerance to them. Not all medications have tolerance. Like when we talk about blood pressure medications, they're going to work the same regardless of when you take them or however long you take them. People have been on blood pressure medication for years on the same dose and they work just as effectively. But we know that opiates are ones that you can develop a tolerance to. So when patients say, after a while, this pain medicine just isn't working as well, they've probably developed a tolerance. It's not necessarily they're just trying to get more medicine to misuse it. It's that they're experiencing pain. Now, there's also physical dependence. Once you've been on opiates for a long time, you can start to, if you don't have them, you kind of, we thought not weaning off of it, but you can start having physical responses when you stop taking it. A lot of it is that pain that's rebounding and how you feel off of that pain medicine. And there is true addiction and true psychological dependence on the opiates, right? Usually that's the point when somebody is using them for not just pain, right? They might have pain. A lot of people who misuse opiates, they usually start with having pain, or oftentimes still they can have pain and they can use opiates for the other effects, maybe the psychological effects. They want to be numb from the world. They want to feel differently than they want to feel right now. There's also pseudo addiction. So that's kind of what I was saying. When people have a tolerance that's built up, they might be saying, gosh, I need more. They're calling their doctors, they're asking for more. Maybe they're patients in the hospital who have chronic back injuries and now they had their hip replaced like our other person, and they're used to taking so much opiates, right? Maybe they take 20 milligrams of oxycodone several times a day. And we go, okay, you're on that at home. Let's give it to you here. And we don't give them anything else. Is that going to take care of the pain in their hip? No, because they're already, that opiate that they're taking, the oxycodone for their back pain, that's what keeps them at a level. Like that helps control their general back pain. Now we've introduced a whole new world of pain by having surgery on the hip. So they're going to need more or different pain management. And so they might be pressing their call light saying, okay, it's almost time for my pain medicine. I can get it in 5 minutes. So if I call you now, maybe you can be back in 5 minutes to give it to me. You know, it's people trying to get more pain medicine, and it's not that they're addicted. It's that they're hurting, and it looks kind of like what addiction could look like. Okay, which of these patients is addicted to pain medicine? All right, I like it when we have some varied responses. That's good. All right, so let's talk about each of these. So yes, most of you guys got this correct. It's the patient who continues to take opiates despite the harmful effects. Or I don't really like how this worded the question, but this was directly from F.A. Davis. So I kept it in there because they kind of mimic some of the NCLEX questions. But they're continuing to take it despite a negative reason. Right? We know that somebody who needs more and more opiates to achieve pain relief, what's that called? Tolerance. That's tolerance. That's not addiction. Or the patient who asks for pain medicine before the order time allows. What is that? Might be psychological dependent. It might just be pain, right? And they might be asking for pain before it's available to them because they're just hurting. It's maybe just not enough. And then the patient who's a clock watcher, kind of the same thing, right? They might just be experiencing pain and they're watching the clock because they know you're not going to give it to them any earlier than it's ordered, but they're like, I hurt, so I've got to keep asking. All right, so we talk about pain transmission. So going back to the example, if I smash my finger in the door, the transduction is when my body takes the physical stimuli, the door slamming on my finger, and it changes it into this impulse that then, by transmission, travels up my nerve endings to my brain and tells my brain, ouch, that really hurt. We have our perception of pain, but then we also have modulation. It's our body trying to say, it's okay. You're going to be okay. Like endorphins are one of those things that your body produces to help modulate or help control pain or offset pain.
I have a question.
Yeah.
So why is it that the brain and the spinal cord are the only ones that are triggered when they're in pain?
The brain and spinal cord aren't the only things triggered in pain. And it's just one of our pain pathways. Yeah. It's one of the main pain pathways that we have. Which, going into different types of pain, which type of pain occurs with tissue damage? Is it the nociceptive or neuropathic? I like to think of the spinal cord and brain as kind of like the information highway in our body. It's what's sending the signals back and forth. And most of you guys got this right. So nociceptive, that is where we have either pain in our muscles, our bones, our organs. And then neuropathic is when we have pain that's in our nerve endings. The nerves themselves are damaged. And those actually feel very differently, usually. So tissue damage, if I smash my finger, right? What might people describe that as usually? Like, what are some descriptors people might say? Throbbing, maybe stabbing or sharp. After a couple of days, it might just be aching. You know, there's a lot of those types of descriptors that people usually say for nociceptive pain. For neuropathic pain, pain involving our nerves, what are some types? How do we describe neuropathic pain usually? Tingling pain. Tingling, burning, numbness sometimes. So that doesn't mean that has to be how they're described, but typically when we experience those different types of pain, that's how people will generally describe them. So that's partially how we diagnose, right? Or we look at patients, we say, well, you know, tell me about it. Can you describe that pain for me? Because that lets us know, where is this pain coming from? What's the cause of this pain? I love this chart just because we tend to have a lot of referred pain in our body. So for instance, most of us know our appendix, right? That little pouch off of our intestines. We usually will have pain kind of up in this area, right? Anyway, we'll go more into that later. Or if we have kidney issues, where's our kidney at listed here? A lot of times we have that flank pain, right? What else do we have? Oh, the heart. See how the heart has this red and it's at that left side of the chest going down the arm, also in the upper back a little bit. So depending on different organs that are hurting, people will often feel them in a different, like it feels like pain in a different part of their body. It doesn't mean that if they say they're having, you know, they might be having a heart attack, but they might be having just stomach pain, right? It might feel differently, they might say differently. But typically, this is kind of what it looks like. I will say most of our studies from this stuff were done on white men. So not like if you're an exam on a white man, these will be really good usually. If it's somebody who's a woman or a person of color, it might not be as accurate. It might be, but just know most of our studies, you know, they weren't done on a very diverse population. So we just want to take that into consideration. All right, a patient requests pain medicine, but they don't appear to be in pain. What action should the nurse take? All right, you guys are good. Do a thorough pain assessment, right? Let's find out more about it. I hope that every time that you guys give a pain medication, that you do an assessment beforehand so we can really truly find out what that patient is experiencing. Yeah.
We can't just order or give medication though, right?
No. I guess what I'm saying is, if the pain medicine is ordered, even if it's ordered, we still want to find out what are they experiencing. Tell me more about your pain. Yeah. We don't want to just not administer the pain medicine, right? Administer half of the order dose. That's actually writing a new order, right? Like we can't just change the order and then advise them to wait until pain occurs. Well, they're saying that they're hurting, so we do need to do that assessment and find out more about it. So pain treatment, we have a lot of ways that we treat pain. I've been talking a lot about opiates or narcotics. There's also non-opiate pain medicines and adjuvant medicines that can kind of help in other ways. Is this where I go to? Oh, almost. So anyway, so placebos, I remember when I was a baby nurse, how some nurses would go and they'd be like, this patient's a clock watcher, he's in pain. I don't think he's hurting, he's doing all these things. So they would go in with a saline flush and say, here's your pain medicine. And they would give them saline. And then sometimes the patients would say, oh, thank you, I feel better. Right? That's a placebo. But that's also very unethical, right? Placebos really should only be used with the patient's knowledge in some sort of research. And when I say knowledge, like if you're in a research study, that's how they know if a medication works or doesn't work, right? Because maybe the two of you guys are in a research study. You get the real med, you get the placebo, but none of you know. We just give it to you and then we say, okay, let's talk about your effects. Let's see how you feel. And then afterwards, once we have a large group of people, hopefully the people with the placebos don't really have much of an effect of anything, but the people that got the real medicine, they do see quite a big effect. That's just part of how they do drug research. So it's very unethical to do what that person did, right? Because if that person is hurting, we need to do a pain assessment. We need to see what's going on. Maybe they truly are not hurting. Maybe they have suffering. Maybe there's addiction. But we don't want to lie to them and then also say we're giving something we're not giving. So the routes, how do we give pain medicine? We're talking about actual medications. So a lot of times talk about orally, right? Very common route of medication. You can also do rectal, like suppositories. Sometimes people who can't tolerate the oral route, we can do rectal. There's some actual inhalation treatments. As medicine, I've seen some kind of trends that we're getting more and more inhaled medication. There's a really cool new inhaled insulin that's out there now. I don't see it a lot, but I've been seeing commercials and things for it, which is cool. Those patients who hate to stick themselves with diabetes, they're maybe a lot more comfortable just doing an inhalation. Transdermal, what does that mean? On the skin, yeah. What kind of medicine is usually in a transdermal or in a patch?
Lidocaine.
It could be lidocaine. Fentanyl. Fentanyl patches, or like fentanyl can often be in a patch. Which fentanyl, it's so funny because people nowadays are so afraid of fentanyl. And it's so funny because for me, I've worked with fentanyl for decades and we've used it for a long time and it's an incredibly effective opiate. However, it's very potent, right? So we give it in a very small doses. Where morphine, we might give 1 milligram up to 10 milligrams, maybe. Fentanyl, we do micrograms, right? We give very tiny, like 12.5 micrograms, 25 micrograms, very small doses, which is so important that we know what our unit of measurements are, right? Like we don't want to make a drug mistake and give milligrams instead of micrograms for fentanyl. But fentanyl is so effective. It's so effective for pain medicine or for pain management. And there's lots of patients. I told you guys I work in like the surgical area. And there's patients who come in and they're like, I just don't want fentanyl. And I'm like, oh, tell me more. They're like, I don't want to be, all those people are dying with fentanyl. Oh, yeah. And I'm like, oh, okay, I hear you. Thank you for telling me how, thank you for sharing that with me. However, the fentanyl that's on the street, right, it's so powerful. They cut it with other drugs and it's so much, it's not controlled, right? Where the medicine that we give patients, if we're giving them fentanyl, it is very controlled. We give them in very small doses. We are monitoring them in a special environment. It's very interesting to me when patients first started saying that. I was like, Who doesn't want fentanyl? It's a great drug. It's very, and the beauty of fentanyl, by the way, is it's very fast acting. Where morphine will usually take about 10, 15 or so minutes to even start working. Even IV, fentanyl is usually within minutes it starts working very fast. So I think especially in surgical, when somebody's having a lot of very acute pain that's serious, it works so fast. It's so good. You'd think I'm like addicted to how I talk about it, or that I had like stock in some sort of fentanyl. I do not. Okay, let's keep going. Intramuscular. Intramuscular is another form or a method of how we can give pain management. I do not suggest doing this, more, especially opiates, because it is not a consistent absorption rate, right? If we give something IV, we know it's going into their bloodstream, it's being absorbed rapidly. If we give something into the muscle, depending on how big the muscle is, how muscly they are, their vasculature, all of that, that's going to affect how that absorbs. And so it's just not consistent. So you can give an IM shot of morphine, something like that, but it's going to absorb differently, and it's not the preferred route. Okay, that's all you have. You have no pain pills, or somebody can't eat. We have no IV access. It's something you can do. It's just usually not recommended, but possible. IV, right? Very fast working. PCA is patient controlled analgesia. Have you guys talked about that in foundations? A little bit. They're great. They're hooked up to your IV, and they'll have a syringe of morphine's the most common. You can also see fentanyl or Dilaudid, some of these other medicines, and it's programmed where the patient gets to deliver their own pain and medication, but it's programmed with lockouts. So you can sit there all day and push your little button, and it's only going to deliver a dose once that time frame says it's okay. Usually it's about every 5 to 10 minutes. You can say you can get another dose. So anyway, they're very good, especially if somebody needs continuous small doses of pain to keep them managed. It's usually right after surgery.
Yeah. Like before giving birth, with that tiny button, I remember like it was controlling my pain just for a little bit, but I have to get it like every hour, and I was like, oh, I can't get it yet.
I don't know about before birth.
I remember that when I had my first kids, Christian, I remember they given me to control the pain just a little bit, a pain thing.
Oh, that's cool.
Pressing the button, but I had to wait it only lasted for like 5-10 minutes to relieve the pain, and then I had to wait like an hour. So I'm like, oh,
yeah, which is a really good point about IV medication, because it's in our system, it's circulating so fast, it's also metabolized very fast, and it does not last nearly as long, right? Where if we give something orally, it has to go through our stomach, dissolve. It's going to go through our liver, right? It lasts longer because it takes longer for it to break down. Transdermal, topically, those usually it's about 3 days. Those patches can last for quite a long time. Subcutaneous. So we do give subcutaneous pain management. Usually that's more hospice care when patients are dying. Occasionally they will give it to people, but usually that's like hospice care where you'll see it more. And then we also have intraspinal. So kind of like we think about patients that might have to have a epidural, which is, I don't know if I want to get into all that. There's different, depending on where you give the medicine, if you go into the epidural space or if you're going in, anyway, there's a lot of different ways to either numb or give pain in the spinal area. We don't have to get into that right now. We just know that it happens. Oh, here's the medication activity. How about we take a short break, 5 minutes, and then we'll come back and we'll do our dice activity for the day. Yay! I'll have enough energy for all of us. Resume. Okay. If you're watching the video, you just got to figure out NSAIDs on your own. We do know that NSAIDs can disrupt platelets, how they stick together. And so there might be an increased risk of bleeding. And they can cause constipation, not very often though. COX-2 inhibitors They reduce pain and inflammation also in the periphery, but they don't have the same bleeding effects or the same effect on the platelets, which is nice. So Celebrex is a common one that we use for the COX-2 inhibitors. This is a prescription medication where the ibuprofen and naproxen are over the counter. Ketorolac or Toradol, that one in the middle, that one is a prescription medication. So the COX-2 inhibitors, they also are pain and inflammation. They also can be irritating to the stomach. And so we do want to give those with food as well. So opioids or opioid combinations. So they bind to the opioid receptors in the central nervous system. So, and when we talk about pain receptors and all these things, it means that we have these little frond things, and that's how we can receive the pain stimuli. And they come and they bind to those pain receptors. They maybe can't bind to all of them, but they can bind to enough that our perception of pain, what we're able to get from that stimuli, is actually reduced. So fentanyl, hydromorphone or Dilaudid, morphine, those are all, or oxycodone, those are all opioids. One thing I want you guys to make sure you understand, the like MSIR. Do you guys know what IR stands for? Instant or immediate release. What would be ER stand for? Extended release. Would we ever want to crush extended release?
No.
Why is that?
They're supposed to take longer.
Right, because extended release medications, they're usually larger doses that are parsed out as it's extended released. If we crush it all up, that just makes it available for one whopping dose that might be potentially harmful. So we give it for pain. It can be combined with a non-opioid like acetaminophen or Tylenol. So that's where we see like Percocet. Percocet is a very common medicine, oxycodone and acetaminophen together. That's Percocet, same thing. It's just that they combine it. Tylenol or acetaminophen is not a strong pain reliever, but it does help to relieve pain to some extent. And so when we give it together with an opioid, you can see how like 1 + 2 is 3, right? It does help a little bit more. We do want to monitor, especially for sedation, because we know these are working on our central nervous system. They're going to be depressing our levels of consciousness, especially breathing, right? Our respiratory rate. We really want to monitor for that. Avoid fentanyl patch in patients with a fever. The heat is going to increase the absorption, right? They're going to get a bigger dose than we really want them to. We know that opioids are going to cause constipation. In fact, all of the side effects of opiates, we talk about opiates can cause nausea. They can cause urinary retention. There's all of the sedation, the respiratory depression. All of those side effects of opiates get better over time. The longer you take them, just like the actual how much it helps you with your pain kind of decreases, all those side effects decrease, they go away, except for constipation. Constipation is the one side effect that will stay with you regardless of how long you take opiates. So you'll notice if some patients are on opiates for a long time, like our back injury person, they're usually on some sort of bowel protocol or regimen where they take things to help them poop, because that's one thing they're going to struggle with, is they're going to be constipated. We don't give codeine in pediatric patients. Okay, corticosteroids. Well, I don't know why I put corticosteroids there twice, but it's going to reduce the inflammation, right? So some common corticosteroids we do: prednisone, methylprednisone, dexamethasone. Anytime you see that ONE, the ONE, that lets you know that's probably a steroid. That's something you can get clues. We want to give it with food. We want to monitor for increased blood glucose level. We know that prednisone or those steroids are going to probably increase somebody's blood sugar levels. It can also really make you feel jacked up and have very labile moods. So a lot of times people, especially if they've not taken prednisone before, they feel like they're bouncing off the walls, crawling around, they're hungry a lot. And I like to just tell people like, hey, you're going to be on this medicine, you might feel a certain kind of way. That way, they don't think they're just like losing their mind when all of a sudden they're like, I just am going nuts from this medicine. All right, anticonvulsants. We talked about this last week too a little bit. So they suppress the transmission of pain. Gabapentin and Neurontin is a real common one. We like to use it to treat neuropathic pain, that nerve pain. We do want to monitor for falls, and it needs to be taken regularly to get a full benefit. So it's not like an opiate where you can kind of take it when you need it, when you're feeling more pain. Gabapentin, you need to take on a regular basis to really get a full benefit. It might help with pain if you just take it once or twice, but really on a regimen is where you're going to get your full effect. And gabapentin, I didn't put it up here, but it's one of those medications has a very high ceiling, meaning a high level of what's effective or a safe dose. People start on a very small dose of gabapentin, but you want to make sure if they're not getting relief, they might need more and more. And it kind of takes a while to kind of level them up to this very high dose. So just because somebody starts and even like a month in, they keep raising up that level, it might mean we're just not to the dose that works for them yet. So it's got a high ceiling on it. Tricyclic antidepressants, they also can help relieve nerve pain. Amitriptyline or empramine are often ones that we use. They can have some anticholinergic side effects, which we think about, I think about things slowing down, drying up. So your eyes might be dry, your mouth might be dry. You might retain some urine. And then last one are serotonin or norepinephrine reuptake inhibitors. And again, we talked about like our little receptors, like we have serotonin receptors in our brain. And serotonin and norepinephrine, those are kind of some feel-good hormones, right? Like they make us feel better. And we have it circulating in our brain, and we have these little receptors. And so if I'm on a serotonin reuptake inhibitor, that means instead of the serotonin coming and latching, like and being taken up or going away, it's blocking it so that more of that serotonin can stay in my brain and keep me happier. That makes sense. This means there's more available to you. It can be very effective for nerve pain as well as depression. It may take weeks for the effects to be seen. So it's important, whether we're giving it for depression or pain, that these serotonin or norepinephrine reuptake inhibitors, we're letting them know you're not going to feel good right away. You got to keep taking it every day before we even see if it's working for you. Because sometimes people will take it for a week and they're like, it's not working. I don't want to take it anymore. You might just need to stick it out for a little bit longer and see. Okay. All right. So now that we went over this, bloop, 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 here's your, I've got a little handout for everybody, but I'm going to put it up here too. So if you weren't here last week, or if you just forget, the first person is going to have the sheet, the answer sheet. Like, looks just like the one we went over. And you'll roll the dice. I only have 1 through 7, so I think each group I have 7 medicines. We'll just do 1 dice. And so if you've gone over, if you roll something you've already rolled, just do the 7th one. So the first person, you'll roll the dice and you'll say the medication that's on there. And then if this is my group right here, then I would say, okay, then the first person, you state the action of the medicine. And then I'd say, oh, right, next one, give me an example of the medication. Hey, good job. What is it given for? And then maybe what are some nursing indications? We can help each other out, but that first person, whoever rolled, they're the one that's kind of going through. And then I would hand off and give to that next person. They would roll the dice and kind of go around as a group. All right, so get into groups of 4 or 5, and I'll give you your papers and your dice. Yeah. All right, so let's go ahead and let's join the Menti again. If you're out, go to menti.com and use the code up here. I also wrote it over here.
Do you have a copy of the one we just did, this one today?
I have.
Online.
Oh, and oh yeah, I have one. So also online from today, I'll put it in the resources. Yeah, keep that one. I do put them in the weekly resources. So if you guys aren't familiar with, does anybody look at the resources page?
Yeah.
Yeah. Okay. So let me just show you some of the things I put in here. Because I know that everybody learns a little bit differently. And so I want you guys to all have access. So typically, thank you so much. So I put the PowerPoints in, which I know a lot of you guys get. After today, this is where I'll put the Menti. You can look over a PDF of the Menti if you want to review some of those things. I'll upload the recording here. The medication activity, I'll put the answer sheet on here so you guys can have the answer sheet. I also do a lot of visual aids too in the weekly resources. This one's kind of fun about hot and cold, when to do it. So like this one is no heat. If you can't feel, like if you don't have good sensation, don't put heat on your skin, right? We don't want to burn you. If you're actively bleeding, we don't want to put heat on there, right? Because the heat's going to vasodilate, let more heat or let more bleeding happen. Versus cold, if you have lower circulation, you don't want to add cold to somebody's skin. That's going to vasoconstrict, decrease the circulation. So these are kind of nice little visual aids. It has some of the pain medicines as well. So look through the weekly resources page. Each week has things that are specific to what we're looking at each week that are good to help you study. All right, so back to the Menti. Once you're back in, would you give me a little emoji so I know who's kind of in, if we have most people kind of captured on here? There's a lot of cat people here. You can also join from your phone too. All right, so now that we talked about medications, let's talk about some non-medication therapies. So there are things that we like to use for pain management that aren't necessarily medicines, right? So cognitive behavioral, those are things like educating patients about pain. There's a lot of times, I think about when I start an IV on patients. I like to make sure they know after I start the IV that, hey, there's not a needle in your arm anymore. That needle goes away, and now you have a little thin plastic tube in your arm. You can bend your arm, you can move your arm, and you might feel it in there, but it's not damaging anything. A lot of times, just being educated and knowing about what's happening helps to decrease that pain that they're feeling, right? Sometimes we have people use relaxation, imagery, distraction. We might use heat, cold, massage. We're going to get into this more in a little bit, so I'm kind of going to gloss over some of these things. You guys have done the What's Up assessment before. A lot of you guys talked about it on your homework this week. Good job. It's a really effective tool, especially for pain assessments. Let's talk about pain scales, right? Because the patient's self-reported pain is the gold standard. So sometimes patients have a hard time understanding, like, what does that mean? When we say 0 to 10, this is a pretty standard scale. 0 is no pain, and it goes up to severe at the worst pain possible is 10. Sometimes it's really hard for patients. So we'll use things like the FACES scale. That sometimes can help people to say, oh, they look good. They're a little distressed, getting worse, till he's just like, so hurting, right? That can be helpful, especially if you have somebody who maybe doesn't speak the language very well, right? This can be very helpful. We also have the pain and advanced dementia, right? Because patients with dementia, they're not thinking the way that we would normally think. And so we use some other indicators, some objective data to help us. So I talked about their behavior. Is it normal? Are they hyperventilating? Are they have noisy breathing? Negative vocalization, that's groaning, right? They're hurting. Their facial expression, are they neutral? Are they frowning? Their body language, right? Are they kind of tense? Are they moving and fidgeting? Maybe they're like pulling away. They might even be hitting, right? So people in dementia don't think in a normal pathway. They're experiencing that pain and they don't know what's causing it. So they might be striking out. So we got to be careful, but it also gives us clues. They might be really hurting. And then consolability. Are we able to talk to them and reassure them? or does nothing really help? They're still not able to kind of calm down. That gives us a score to tells us like how, where their pain might be. Now, is it the gold standard? No, we'd love for them to be able to self-report. If they can't, we're going to use other tools. Oh, that's right. I wanted you guys also to see the FLAC score. And so I copied it. So this is not the PainCAM score for dementia. This is the FLAC score. This is what we would use in kids and babies, right? Because in babies, they can't tell us if they're hurting. So we look at their face, right? Very similar to the dementia pain scale. We look at their legs, right? Because in babies, if they're like tense, curled up, sometimes that can be a sign that they're in pain. We look at their activity. Are they moving all around? That might be because they're distressed. Are they crying? And then again, are they consolable? Can we calm them down? That gives us some objective data points to help us see if patients are, especially our pediatric ones, are in pain. We also often use a sedation scale when we're assessing pain, because oftentimes the medications, opiates, things like that, can be sedating. So we want to make sure our patient isn't too sedated. So we look, if they're just asleep, they're asleep, right? That's just different. But they might be awake and alert. They might be kind of drowsy. They might be frequently drowsy, kind of nodding off. Or we might not even be able to wake them up, right? And so if we're talking to somebody and they're saying they're having so much pain, but they're like drowsy, they're nodding off while we're talking to them, that gives us an idea of how we want to treat that pain, right? Because do we want to give them an opiate or something that's going to depress their central nervous system? No, right? Because I don't want them to go from drowsy to unable to respond. We want to be wise or use our critical thinking with how we treat patients. So which pain scale would be the best for a confused patient with a history of dementia? All right, good job, you guys. The PainCAM scale. All right, so patient education. We want to talk to them, if they're on some pain management, specifically medications, that they might have some fatigue, right? A lot of these medications are working on the central nervous system. They're not going to be as get up and go-y as they want to be sometimes. We talked about constipation, especially with the opiates, and that doesn't go away. That's going to be the side effect that stays with them. We're going to have to keep treating. And then we also want to monitor for their vital signs, specifically respiratory rate with opiates. One thing I want us to make sure we're teaching patients about our total acetaminophen doses. We talked about some of our combination medications like Percocet or Vicodin. They have an opiate that's combined with Tylenol. It's great, super effective. Sometimes patients take that and they're like, man, I'm still hurting. I got this bottle of Tylenol. I can take this too. This is over the counter. Not realizing that maybe acetaminophen and Tylenol are the same medication. Right. What's the total amount of Tylenol or acetaminophen we want people to have in one day?
I was gonna say under 1,000, 3,000. I guess 3,000.
Okay. You guys, I want you to look this up, and next week I'm going to ask you. Okay? Because there's a certain limit that we want people to keep under. All right. So that's part of your homework. I'm going to ask you next week. Or I'll ask it on that. I'll ask it on an announcement. And you guys answer. All right. If we have too much acetaminophen, what organ does it affect?
Liver.
It can cause liver damage, right? And so that's important that we know. Yeah.
So I kind of overdosed on acetaminophen after I had my daughter because I was so scared that I was going to be in so much pain from my son. So I got to be on top of my pain medication, acetaminophen, boom, boom, boom. And I wasn't thinking because I was like, I don't want to be in pain. Yeah. So I overdid acetaminophen and I had super bad stomach pain. Like, I could not move. I had to go to the ER and they said I was like borderline kidney infection because of all this extra stuff.
Interesting.
Yeah.
Okay, I'm glad you're okay.
Yeah. Yeah. But I was just like interesting.
All right. So one thing I want to make sure we know is that if somebody gets too much of an opiate, we do have opiate reversals that are available. So naloxone or Narcan. It's become pretty, not common, but people are usually aware of it because of our opiate and addiction crisis. We now have Narcan available in the community a lot. How do we give it in the community? The nasal spray, right? Usually in the hospital setting, I haven't really seen it as a nasal spray. I usually see it given IV. It's very fast absorbing. Actually, in both routes, I think it's a little bit faster in the IV. We'll see. So anyway, with Narcan, there's some things we need to be aware of. We talked about our half-life of medications with pharmacology, right? What does half-life mean? Yeah, it's the time frame where about half of that medicine is out of your system. Helps us to gauge how long before we give the next dose, right? There's certain medications, heparin is one of them. You give patients subcutaneous heparin, it's out of your system in about 8 hours. Heparin subcutaneously is given about every 8 hours, so you get a therapeutic effect. Narcan has an incredibly short half-life. It works very fast, right? So if somebody is very sedated, they're breathing only a few times a minute. So maybe we have this person, they can't wait. Oh yeah, their respiratory rate is 4. They got a big old dose of morphine. We thought they'd been taking morphine at home. So we thought maybe they could tolerate a 4 milligram dose, and really it just snockered them. So we give them Narcan. Really important to know that Narcan is going to wake them up, right? They're going to be all those side effects, right? They're going to, not side effects, all the sedation is going to go away. In addition, what is going to come back and return to that person? Their pain, right? Because it's kind of taking away the effects of the opiates. But the half-life of that Narcan or naloxone is very short. So what's going to happen 10 minutes later after we give it? That's how it, depending on how long ago they got the morphine, that morphine is going to be going strong in their system for another hour. We need to make sure we're monitoring them, make sure they don't need more of that Narcan. I probably just told you the answer for this, so let's just kind of go through.
So with that Narcan, would that be considered an IV push?
Yes.
So we wouldn't be able to administer if we have to administer.
I would follow your agency protocol because there's some agencies that will let LPNs give IV pushes. And so I would follow the protocol. So we want to talk about frequency and duration. Like I was saying, with heparin every 8 hours, there are other medications that patients might be prescribed for pain. Let's talk about the Tylenol or acetaminophen. There's a lot of people that use that for pain very effectively. But we want to make sure they know how often to take it and how much to take, right? Because if you're taking a regular strength Tylenol, which is 325 milligrams, that's very different than if you're taking an extra strength Tylenol, which is 500 milligrams. Or some people are on no, we're not going to go there. So anyway, you need to know how much and how often to take, right? We also want to make sure we're looking at interactions because a lot of times, depending on what pain you have, we go back to a person who has a chronic back pain, there's probably muscles involved as well. And they might get some like muscle relaxers and other medications that are going to help with pain. Those can also be sedating. So if we're giving opiates or some other medications that are sedating, and then we're adding in these more medicines that can be sedating, right? They're going to be maybe extra sedating. We want to make sure we tell patients, please do not drink or smoke or do drugs while you are on these pain medicines, right? I know people are like, well, why not smoke? Because it decreases, like, if you're not fully aware, you have a lot higher risk of burning yourself, others, or your house down. And so tell my patients, be very careful. Safety. We want to make sure we teach them if they're going home with a prescription, keep that medicine out of the reach of children. I know there's supposed to be like child-proof bottle tops. There's so many kids who can get into those child-proof bottle tops. So we just want to make sure we're teaching them that. We prefer for them to be locked away if they have that accessibility, or at least just not able to be gotten to by anybody. Sorry, I just missed my mouth. We also want to encourage people to dispose of them when they're discontinued. Nurses are the worst at this, you guys. Most nurses have a whole pharmacy in their home that has medications dating back to the 1900s, which isn't that long ago, but 20 years ago. Because we're like, well, we might need this, and I don't want to go see my doctor, and I'll have it available sometime. But should we really have, especially opiates and some other controlled medications just sitting around in our homes? Probably not, right? Our kids can get into it, our pets might get into it, my weird uncle might try to get into it. It just kind of leaves you open for some things. We want to dispose of them safely. Depending on where you live, they're going to have different ways to dispose of them safely. Most pharmacies in this area have like a safe return policy where you can say, hey, I finished my prescription of oxycodone. I had some left. I don't need them. They'll take it and waste it or dispose of it in a proper way. It used to be we'd have people flush it down the toilet. And then we found that we have a lot of medication showing up in our water systems. And so like just very trace little bits of medicine, but we were like, okay, we probably shouldn't be putting, these medications in our water system. So there's special ways of doing it. Right now, if you can't return it to a pharmacy, sometimes they'll say, crush it up, put it in coffee grounds, dig a hole and bury it. And that usually it'll make it inactive. Yeah. If you are digging up a hole with nasty stuff and trying to ingest that, that's a whole level. Where are we at with time? I'm not gonna do this case study. If you want to look at it later on your own time, we'll do that. Okay, so complementary modalities. So that was chapter 5, I think, in the book. And so often it's called CAM therapies. CAM stands for complementary and alternative modalities. Your book talks about modalities. Therapy is another word for it. So I'm going to try to say modality, but I might switch and say therapy as well. So just know they're kind of interchangeable in that way. So complementary modality, that means that you're using this modality or therapy or treatment in addition to maybe some traditional medical care. For example, you might use guided imagery, helping somebody to relax, in addition to using a prescribed drug therapy, right? It's complementary. It's coming alongside helping out. Where you might have an alternative modality, and that means instead of a conventional treatment method, we're doing something different instead of. So this example would be using acupuncture instead of analgesics for pain. So acupuncture could also be complementary if it was used in conjunction with maybe a pain medication regimen or something else. It just depends on how you're using it. That's what it means by complementary or alternative. Yeah.
Do the nurses do the acupuncture, or do you like call them?
No, we would have a specialist do that. Yeah, I have worked in some facilities that they have people that will do chiropractic care, acupuncture, and pressure. I haven't worked anywhere in the Northwest that's done that. But usually it's outpatient settings where you can refer out to that. So different systems of healthcare, it's important to know, like right now, we are working in the Western system of medicine for the most part. That's what we're kind of learning, right? As we're in school learning about medicine, we're learning about Western medicine or allopathic medicine. There's a bunch of other systems of medicine that are very beneficial and that can be used in conjunction with what we are doing. Oh, group work. Okay. So again, let's just get back into our groups. And this is what I'm going to have you guys do. Hold up. I had it pulled up and then I got sidetracked showing you all the fun pictures. So we're going to go, what I'd like you to do is to go in your groups. Actually, do we have 5 groups? How many groups do we have? Well, we need 5 groups. So in your groups, you're each going to have one of these modalities or therapy treatments, like biologically based modalities. You're going to go to your book on page 43. There's a table that's very helpful in starting you on the right path of looking these up. Then you're going to describe the modality. You're going to give some examples. You're going to say, what are some safety concerns we need to talk to our patients about, teach them about, and then how might you as a nurse assist or guide patients with these modalities? We're really going to spend 5 or 10 minutes working on this. So go ahead, break up into your groups, and I'll assign you your modality or treatment. I'm gonna remember to pause the. Okay, so miscellaneous therapies, go ahead.
Okay, heat and cold, aromatherapy, we're seeing like maybe some lavender,
Mhm. Mhm.
relaxing, chanting, kinesiology.
Mhm.
Okay, light therapy, we're seeing like red light,
Mhm.
animal assisted therapy, like emotional support dogs, assisted dogs, therapy dogs,
Mhm.
and cats.
And cats.
Yeah. Cat lover.
And then were you able to find any safety issues associated with them?
Oh, light therapy, stuff like that, that potentially cause like skin cancer,
Mm-hmm.
burn,
Yeah. Mm-hmm.
animals. They're not legally support animals, they're like wild or something. Yeah.
Yeah.
So much, yeah. I don't know. Have a scent that you're allergic to, you don't know.
Mm-hmm. And then any ways that a nurse might help guide or assist patients with them?
Like pass out brochures or even like give heat packs and hot packs, things like that. Okay.
Yeah.
Yeah.
Yeah, it's kind of open. So nice job. Thank you guys. All right. And then back, what is it? Energetic modalities? The energetic group? So sorry, I'm having a hard time hearing.
Like non-invasive, so it's like therapeutic, crystal healing. It's very like natural, non-medication. There's like therapeutic touch, so hand touching, yeah,
Praying. Okay.
therapy, biofeedback. Yeah. It was all about pretty much what she thought was essentially that the belief is that the body has natural healing powers based upon energy. So that's what the all really identifies exactly. How safety, I mean, she mentions like magnet therapy if somebody misuses or if the therapy isn't working, it can cause like long-term the whatever the issue that they're trying to treat doesn't actually heal. So they need other things to help. And then just, you know, you have to have a magnet on and
Right. Could be a safety issue. Yeah.
yeah.
And anyway, like nursing care and how nurses support this?
For this one, I would say like specifically respecting people's beliefs because it is that is one big thing and being mindful of like what your beliefs are because if you just like a pain medication they help for your spiritual healing that can affect so just being aware of that and just supporting the patient and how they want to proceed.
Yeah, that's great. Thank you. Yeah. All right, our big group in the back, you guys have manipulative and body-based modalities. Okay. Mm-hmm.
One of the things we say is working section of that.
Mm-hmm.
The book mentioned it with that if someone has a that you actually like
Yeah, for sure.
I also know that I know that how do you say that?
Chiropractic?
I noticed that that is a little more like popular,
Mm-hmm.
but there's also people going around to do like people
Yeah.
so I think that's a problem too.
Yeah.
And maybe one thing that nurses could help
I refer to, yeah, that's right. Yeah, a lot of insurance companies will cover like massage care or chiropractic care, but oftentimes you have to have a referral from a medical provider as well. Yeah. All right, so our second to last group are mind-body modalities.
So we did like art therapy, guided imagery, hypnosis, yoga, just some. So like safety issues. We were thinking like there might be some psychotic issues like with hypnosis, might like send someone into like a spiral or something. Like yoga, it's might be harder for people who aren't as like flexible or maybe they have an injury. And then for like what we could do as nurses is like refer them to these things like, hey, maybe yoga is a good option for you, or get them art supplies that, you know, if they have like arthritis, that they're able to use.
Adaptive things, yeah. All right, thank you guys. And then our last group, the biologically based modalities.
Yes, okay. So this one is, again, just natural alternative medicine, just uses natural things. So examples like herbal medications and nutrition diet therapies. There's supplements, vitamins, you know, type stuff to use. Another one is cannabis stuff.
Cannabinoids, marijuana.
Yep. And then detoxing is also one that we found. And then some safety things. It could, I mean, natural stuff can still interact with maybe normal medications that you're taking. So it could like not be effective or whatnot. And then, overdose maybe on natural things. I know like if you drink too much water, it's bad. Yeah, I don't know if you take too many vitamins or too much of something that's natural, it can be an overload of it. So that could be a safety concern, I think.
Yeah, yeah, for sure.
Let's see. How we guide them? Oh, how we guide them is just teaching them about, you know, natural things, having them consult with their doctor first too, even if they're like taking medications, just ask like, hey, can I take these vitamins? Should I do this therapy or whatnot? And just guiding them through that. And yeah.
Yeah, nice. I think of the biologically based modalities as one that nurses especially have a key role in, because we're the ones who do like the medication questionnaire, like what medicines are you on?
Right.
And some of that too is like what over-the-counter medicines are you on? What herbal medicines might you be on? Because we found that a lot of herbal medicines are going to interact or react with some of our medications. Most of our medications that we have, a lot of them are based on herbal medicines or things that are found, you know, in nature. And so, you know, they might be overdoing, you know, a little bit too much. So great job, everybody. I want to go back to the Menti and just do a couple of questions for you guys. Okay, so just a couple, oh, I didn't ask a question. Okay. I think the question for this one was, okay, thank you. So if you didn't hear the question, what herbal remedy might help reduce the chance of you getting a cold? Some of these CAM therapies or nursing roles is to be aware of what medications or treatments or options are available to help guide people with. You guys are so cozy. All right. And correct answer, it is echinacea.
What?
Echinacea is one that we give people to help prevent a cold. Now, I have heard of people with garlic and onions when you are sick to get over a cold or illness sooner. But echinacea is an herbal supplement we give to help prevent getting sick. Oh, again. Okay, what does this one say?
Herbal remedies to the skin.
Okay, what soothes skin lesions? This is a pretty common one.
Yes.
Okay. Yeah, good job, you guys. Aloe vera. Aloe vera is often used to soothe skin lesions or sunburns, like a lot of people have right now. Um, again, oh my gosh.
Which herbal remedy may be effective for depression?
Oh.
I won't say
All right, and St. John's wort. That can help with mood and depression. Absolutely. All right, the next one. Ah, we just talked about this one. Yeah, so Western medicine is often called allopathy. All right, somebody want to tell me what this one says? Body-based or manipulative?
Oh,
Oh, it's not so influenced by.
oh,
It says it, but.
My bad. Right, and the answer is acupressure and osteopathic manipulation. Very similar to chiropractic type care. Okay, so quick check-in. So either you strongly agree or strongly disagree. Do you understand more about pain control treatments after the lecture today? Do you understand more about pain medications and understand more about the nursing care? All right, so we're doing okay. We're kind of moving forward in our learning. It's kind of nice to feel like get a feel to see how you guys are doing. All right, so we've got a little bit of class time left. What I'd like you guys to do is finish the KWL, write out a few things. What did I learn? These are learning tools, you guys. Most of you guys are doing a really good job. I just want to make sure we write down more than just a couple things, because this is the more you write things down or as you write things down, it actually helps to cement it in your brain. So it really is helpful for you learning. After you finish your KWL, if you want to spend the last bit of class time together with your group for your group projects, you're welcome to do that. Yeah. Also, if you are on remediation, I'm going to be going to success class. So anybody that got a 75 or less on MedSurg or pharmacology, I just want to meet with you guys to just go over a few things. And it's not bad. It's just more of kind of just talking about what that will be, what it will look like, and then moving forward. All right, so we'll probably start a few minutes after 10. We'll start the talk. Yeah, let me just stop the recording really quick.